We'll go on to Dr. Martin Roland. We've traversed a variety of sort of conceptual domains, winding up with going through stakeholders and users of the organization, users in organizations of the information, and then really coming down to what's the relationship of the measure qualities to how they affect or can affect what's done with them.
Well, thank you very much. Thank you, Lisa, for asking me to join this session. It's very nice to be bringing a perspective from abroad. I think I'm only slightly further from Washington than you guys on the West Coast. And of course, our context of our healthcare is different to yours. But if anything, if there's any healthcare system in the US that is similar to the UK, it probably is the VA in terms of being a large organization with a single payer. And we have the National Health Service where the government is the single payer. I think some of the lessons that we've learned are the same as the lessons you will learn or have learned. And I'm going to talk about 6 lessons that we've learned in the UK, and we've learned the hard way. And the overarching message taking away from my talk on the right of the slide is just be careful what you wish for. Hoping the slide will advance when I do that. Okay, so it has not advanced. Let's have another go. Right, and the key messages are these. First of all, if you introduce measures with powerful incentives or penalties or rigid targets, they will always have unforeseen consequences. It's a bit like you have a representative of a pharmaceutical company come in and say they've got a really great, powerful new drug and it has no side effects whatsoever. You simply wouldn't believe. Across the world always fail to invest in what I've called the Department of Unintended Consequences, and are then either surprised when they happen or, even worse, don't realize. So the solution I'm going to propose from my 6 examples I'll give you is that you must think about the intended and unintended consequences of what you're going to do in advance and measure both. So the first lesson comes from a target we had to reduce waiting times in the emergency room, which had the perverse effect of increasing hospital admissions. Now, the problem we had was a very clear one. The National Health Service had people waiting hours and hours in the ER. And so a target was introduced to have a maximum waiting time that was from arrival in the ER to departure of 4 hours. Seemed like a good idea. But for some patients, it's actually pretty difficult to meet this target. So imagine an elderly, slightly confused person who comes in, needs blood tests, maybe an X-ray, urine test, need to get the results back from those tests. It turns out actually they're well enough to go home, but they're going to need some additional support. And actually, you can't do all that within 4 hours. And the result was that some patients got admitted, actually who didn't need to be, simply because the clock was ticking. And this showed up quite clearly in a spike in short-term admissions when that target came in, associated with a reduction in hospital mortality. So some people who weren't really very sick were getting admitted who probably didn't need to be. So my second lesson, the subtitle is Don't Always Believe What You're Told. And this relates to alternative forms of access, which may increase rather than reduce workload. And the example we had in the UK was of 2 commercial companies heavily promoting what we call a telephone first scheme, where patients contacting their primary care physician for an appointment would always first be phoned back by the doctor to see if the problem could be dealt with without a physician visit. So the principle was that you would never phone up and book an appointment to go in and see. You'd always be phoned back. And the companies who were promoting this scheme and promoting management support for the physicians said that this produced a dramatic reduction in physician workload and greatly increased patient satisfaction. Well, we did an independent evaluation published in the BMJ at the bottom of the slide, which we showed, in fact, quite the reverse, that it produced a net increase in family practitioner workload, though there was tremendous variation. And we found practices where they found that this had transformed the work that they were able to do. They were much more in control of things, but other practices where they were frankly on their knees because of opening up a flood of unmet need and demand. And likewise, for patient evaluation, it was true that there were some patients who thought this was tremendous, but the net effect was negative, again, with very wide variation. So when somebody comes and tells you they've got a simple method of solving the access problem, just take that with a pinch of salt. Snake oil dealers didn't entirely die out on the west coast of the United States in the 19th century. The third lesson is that alternative forms of access, of which we're seeing a lot now, particularly with COVID, may widen disparities. And our example here is a scheme in the United Kingdom which has been promoted widely by a commercial company called Babylon, called GP at Hand. And what they have done is that they are providing services to NHS patients. So this is within the government-funded NHS, and you join the Babylon practice, and all of the initial contacts are by smartphone. And only if the problem can't be sorted out over the phone does the patient go, sometimes some long way, to a facility for a face-to-face consultation. The result is this. This is very popular with fit young people, and a lot of them have moved to register with this new service. But the way the payment formulae works, which is largely capitation, does not reflect this. And so the commercial company is getting too much money to look after, essentially to look after fit young people. And there's potentially too little left for conventional practice who are left to look after the sick and the elderly. So the points that were being made earlier about looking carefully at efforts to improve access in terms of their impact on disparities is a really important one. Now, my fourth lesson is an incentive which we had for primary care practices to provide rapid appointments actually made it harder for many patients to see the doctor. The problem, again, was a clear one. Patients were having to wait days or sometimes weeks to make an appointment to see their primary care physician. And the indicator which was brought in, which was incentivized, that patients should be able to make an appointment, and practices got an additional payment, a significant one, if they could do that. And the measurement tool was a national survey of primary care patients. So what did primary care practices do? What they largely did was over-rigid application of what I think many Americans are familiar with as advanced access. In other words, they offered unlimited appointments on the day, but limited the ability to book ahead. And the consequence was that patients were unable to book ahead and could only book on the day. And the target was met, but many patients found it harder to make an appointment. And kind of everybody realized that, or at least everybody realized it except one person. And I'm going to show you a short video clip which shows our Prime Minister at the time, Tony Blair, who is doing a live election broadcast with unscripted questions coming from an audience. And you'll see why politicians are extremely reluctant to do live television debates.
Yes, you're actually putting forward targets on practically everything for timescales. I can't get an appointment with my local GP unless it's made within 48 hours. I can't make it 3 days or 4 days hence. I was told that's because they can meet their target that everybody gets it within 48 hours. Why?
Well, I'm absolutely astonished at that. Look, come on, let's be sensible about this. I don't know about this individual case, obviously, but I would be absolutely astonished if you're saying to your GP, I don't need to see you for 4 days, and he's insisting he sees you in 2. The reason...
The doctor is asking you to come back in a week. You can't make the appointment in a week because you're only allowed to make it 48 hours beforehand. This is my son's appointment last week. You have to sit on the phone for 3 hours in the morning trying to get an appointment because you're not allowed to ask for the appointment before that, because by making it 48 hours beforehand, they're meeting the government target.
Is this news to you? I have to say, hold on. That is news to me.
So he didn't like being caught out like that in public, so he goes back to Downing Street and he says, fix that. So the next slide shows one of the problems of fixing it. And it alludes to an issue which other speakers have talked about in terms of reliability of surveys. So having previously had a question about whether people could get an urgent appointment, they put in a second question, which said, are you able to book ahead? The data were derived from a national survey of 5 million patients who are surveyed each year. We get about 2 million responses. And the aim was to provide 500 responses per primary care practice. though the number of responses for some practices was much less, especially in areas with very low response rates. So we were incentivizing practices and giving them a financial incentive based on the responses to this question. Well, first of all, this was very unpopular with physicians who, rightly or wrongly, believed that only the miserable patients would respond, etc. And I think people will be familiar with that sort of response to survey data. But there's a second issue which I want to just touch on, which is that sampling error, which Pat also mentioned, meant that practices could put significant effort into improving access and yet find their incentive payments reduced. Now, if we look at this next slide, on the vertical axis, you've got the percentage of incentive payment that they could get. And on the horizontal axis, you've got the score on the patient survey. And in 2008, which was the blue line, they got no payments if patients, until 50% of their patients were able to say they could get the doctor in the next 2 days. And then there was a sliding scale up to a maximum payment if 90% of patients said that. And they changed this in 2009 so that the practices got no payment unless 70% of patients said they could get to see the doctor in the next 2 days. And then you see a much steeper line up to the maximum payment at 90%. And the consequence of that is that the standard error in achieving, for example, a practice in getting an 80% score was dramatically increased from 3% to 10%. So you could get a practice which had actually improved, but they got less money. And now you may think that's a rather complicated thing to put into a presentation and a workshop like this, but in a sense, that's the point I'm making, is that it was complicated. Nobody understood it. And it was one of the reasons why the measure was discredited in a major way. And it makes the point that actually introducing some of these things with significant incentives or penalties attached carries significant risks. My sixth lesson, which is the constant focus on access, which we have had in the UK for now 20 years, has made continuity of care worse. We don't measure continuity directly, but what we have had for the last 10 years is a national survey in which we've had over 1 million responses a year, where we have asked patients, first of all, do they have a particular family practitioner who they prefer to see? And for those people who say, yes, I do, we ask them, how often do you get to speak to that doctor? And this graph shows the percentage of those people answering always or a lot of the time, which you can see has gone down from 70% 10 years ago to below 50% now. Now, there are other reasons for this, part-time working among family practitioners and so forth, but the constant focus on access has been a major problem, which has resulted in reduced continuity of care. Now, you may say, does that matter? And the answer is, yes, it most certainly does, because in the last 10 years, we've had really increasing and now very convincing evidence that better continuity of care is associated with a whole range of really important outcomes, not just patient satisfaction and physician job satisfaction, quality of care, adherence to medications, and the other things that you can see on that list. So having focused so heavily on access has potentially had a deleterious effect on a range of other really important outcomes. So the overall message is, as I think we know, improving access is not straightforward. Measuring access we know isn't straightforward because of the wide variety of ways in which we can conceptualize access, and we've heard about that. But measuring it isn't important either. And for all initiatives to improve access, we have to think about what the unintended consequences are: potentially increased disparities, reduced continuity of care, reduced access for planned care. We must beware of supply-induced demand, because some of the things which will increase access may not increase needed access, thinking of what Lillian was talking about earlier. And then finally, when you thought about all of the intended consequences and all the possible unintended consequences, keep measuring both of them and be careful what you wish for. Thank you very much.